of my question was, are there big differences between FDA marking and CE marking regarding AI right now?
I don't view this as a big difference. I'm more used to the US side because there was a difference in PMA and 510K specific to the FDA. But regarding AI, I don't anticipate big differences between the two. It's PMA and you.
In CE marking, I think they are the beginning. UK is doing something rather strategic to evaluate, assess risk of AI technology. So I think in Europe they are perhaps the more advanced in this type of evaluation. But I think are still ongoing.
Another way of answering your question, if you wish, for us, AI will be the diagnosis as a biomarker. The way you get a biomarker approved is by a clinical investigation. We'll do the same way, whether the algorithm is an algorithm or a neural network.
Concerning the CE marking, sorry, I'm not completely sure, but I heard a lot of discussion. I think most of the solutions with AI are blocked when they are sold, and they don't go on evolution. And the research on the side is still going on doing the evolution and the self learning of the solution, and then they do another step in the CE marking and introducing. But as far as I know, most of the solutions are not evoluting, and that's a big. In this case, you can consider when you sell something, it's blocked. It's no more evolution. Not it's a a medical device. It's a solution, IT solution, but it's not moving. And there is only one actor who told me that he has a CE marking on a still evolving solution, which is Diabloop, which is a solution for pancreas, artificial pancreas. But it's not very clear for me, but I think it's in contradiction with CE marking. And they told me it's only on very small parameters to adapt to the patient. But the fact is, in fact, you go back to a basic solution software because you don't have no more evolution. And the UK is starting on something which can still move, but it's not a CE marking. They go on the way of CE marking.
Morgan, do you have a question on mine? Not yet. Okay. Do you have?
Yeah. Sorry, just comment. What I learned from your presentation is that you sell it first as a quantitative tool. You don't talk about AI for regulation purposes.
Yeah, and in fact, I think what's important to the way you view it when you are the regulator is that you have a software that does an operation. It's given that the software shouldn't change once you have approved it. So you have a software, whether it's an algorithm or a neural network, which to me is another algorithm. It's just another, sometimes you don't understand what it does, but it's another algorithm. You fixed the whole parameters of the neural network, which is you fixed the algorithm, and you analyze the performance of the algorithm on a set of data. You run a clinical investigation, you have conclusions, and this is approved because it has some given performances. They agree on the performance, and they give you the authorization to sell. Of course, you don't have to change it. That's the way I think one should view the approval process.
You want to answer?
No, perhaps just concerning FDA approval, or also what you very because concerning what is diagnostic or not, and I think the big difference is when you substitute to the physician, in fact, because and I think there is an application who has FDA approval who substitute to the physician, and it's ophthalmic application to read the la rétine, in French, retinography for diabetic patients, where they do the diagnostic without any physician intervention. It doesn't help the physician to be more efficient in the diagnostic. It is a substitution of the physician. I think it's what you wanted to separate when you... the step is really not the same, because in that case you have the fabricant has a responsibility of the diagnostic which is made.
And I think the context of use is extremely important to consider. When you are providing a device, an ultrasound device, to a radiology, the goal of the radiologist is to give a diagnosis. When you are providing your device to a endocrinologist, for instance, the goal is slightly different, because you do not exclude to use a radiologist after. We see that more as a triage of patients, because there are going to be a lot of patients to be analyzed, and the goal is different. The goal is not to have the exact answer. The goal is to make sure that you have the right alert, the right alarm, and when you are above, you do send to the radiologist for further exam. When you are below, you do not. So you have to make sure that you are very strong in the negative predictive value of your device, because you don't want to lose a patient. But the context of use is different and has different implications in front of the regulatory entities also.
You have more question? Yep.
Yeah. So Daniel Hibou, I founded Intense, who is working on diagnostic and prognostic tools for intensive care units. Okay, so when you sell AI, at the end you sell algorithms, okay, but how do you manage the fact that you have to explain the results of the algorithm, and how do you protect at the same time your algorithm?
So the short answer is I don't know, but I think that if you do create an algorithm or a neural network, if you do estimate the weights of a neural network by a training set, and you validate that training set, it's a black box. Of course, we've always said FDA doesn't like black box, but they have to be open to black box now that there's a lot more neural networks on the market. And you validate it the same way you validate a biomarker. When you do a validation of a biomarker, of course, you should have a little opinion about the method of action of your biomarker, but at the end of the day, what prevails is the result of your clinical trial. So you validate it and you sell it, and of course you don't say what's in it, you don't describe it, because you don't know how to describe it by definition.
When your product will be on the market, do you think?
2020 and 2021, but we will not have AI diagnostic tool on this product by end 2021.
Yeah.
Philippe, I'm software engineering manager at the AI4DIAG. You said I think the key in artificial intelligence in the deep learning part is the black box issue. So it's very hard to accept something that we don't know what is happening inside. But what if we consider this black box as a building block in a whole workflow? You have shown in the PowerPoint the biohacks algorithm used by radiologists. What if we insert AI building blocks in each step, but following the algorithm used by the radiologist? I think the market is more prepared for this approach instead of that's here, is the result, the final result. If you get in an intermediary step to adoption to the artificial intelligence, might be easier. How do you see this difference between adopting biological workflow and using the black box? That might work, but we don't know what happens inside the black box.
Perhaps the first answer, and then I share the answer. For the process, blocks in the process of the pathway of the patient, I think it will be, the acceptance will be also linked to the risk which is in the tool that you will provide. Working on a workflow or even I give the example of people providing CT scanner, which introduce artificial intelligence to optimize the dose of the delivered to the patient. I think the radiologist is not really is not very concerned directly. There is no risk for him. If it's a tool, we will do the provide a diagnostic or influence his diagnostic, for example, then he will be more concerned, and his job, and I think he will be asking for what's going on and what are the rules behind. So for me, it's more linked to what you are providing as block of artificial intelligence and what is the risk for the physician using the tool.
To be honest, I don't know how to apply what you described to what we do. I would, and maybe we can take that offline because I'm interested in this. The one thing that what you said makes me think about is that the step in between the diagnosis and the machine that we propose is the measurement of physical parameters. So this, we know that what we do is related to an algorithm that we can explain, and there is no issue there. We are able to measure, for instance, tissue elasticity. And by the way, FDA has already cleared that, so we will use 510K for that. The link between elasticity and fibrosis, today, when there's no AI on the machine, it's done by the community. And the community is doing more and more clinical evaluation. When you have sufficient publication, there are hepatology society meeting all together. They discuss what should we use as a cutoff. And okay, the cutoff of 14 is interesting. It can predict with higher confidence that you have stage 4 fibrosis, for instance. And once they've done that, it's used by everyone. I think that we can plug after that and say, okay, what we put on the machine is simply what the society has said. If you want to do more than this, I don't know how to put intermediary steps in the pathway. I don't foresee that, but I'm willing to discuss that.
More question?
Yes. So the images that you are collecting, do you share the benefits of their usage with the initial owners of the images? Or are you using it for free?
No. Today you can't use it for free. You have to create a framework in which you use it. What the idea we have is in the future to create community of users. What we believe in is that when you think about ubiquitous ultrasound, you are building a community of users. Think about, and again, same trend that we see in photography, community of users of pictures in Instagram, or we create community of users, and this community of users create knowledge. The concept behind this is and I think, I really believe in that, and this is not me saying that, it is the CEO of a big pharma company from China. They were saying that in the Western world, medicine has grown with time. You learn a lot because you observe in time the evolution of diseases. In China, they don't have time, but they have a huge population. So what they're going to leverage is this volume of data rather than a small set of data in time to build medical knowledge. And this guy was actually purchasing data sets from hospitals in China to build these things. And he's not the only one doing that. And Watson is going after every big hospitals, and if they have good data set organized, they are buying that in order to develop their knowledge. For us, we are not there. We are just going to create a community of users and develop knowledge and redistribute that amongst the users.
Yes, just because I'm not sure for a question, but I know a financial model which is existing today linked to the usage of data. So it's one of the company I described which is providing the data to anyone who want to access to imaging data. So it's images and report and so on. And when they have, for example, pharmaceutical industry asking for 3,300, I don't know, mammography and so on and so on, they have hospitals which are partners, public or private, and so they can access to the data, find the good data, get them out of the establishment, and provide them to the pharmaceutical industry, for example. They deal with everything, patient information and authorization, CNIL declaration, and so on and so on. And at the end, they will be paid by the pharmaceutical industry, and they reverse a big part of this amount of money to the partner hospital, so the hospital which are partners of them. So that's I don't know if that was a question, but that's a way of going back to the information providers.
What's the name of the company?
Huh?
What is the name of the company?
C'est NTA.
LTA?
NTA, it's a startup.
You have a question? Who are you first?
Iñaki Sampora-Marzal, data scientist at Urbanova. It's for this topic. In your business model, is it access to reimbursement is important, or
yes, but yes, oh yes, but there are reimbursement codes for ultrasound exams existing today, so we don't start from scratch. We have a base, and of course, as everybody working in this field, we hope that adding more information, adding more performance in the diagnosis will lead to a new or an increased reimbursement. But we start with what exists today, which is the ultrasound reimbursement exam.
And do you have a patent for your software for the software?
Yes, we have several patents, and we are continuously building patents, creating patents.
Thank you for your full participation. And if you have any question, if you want to discuss with our speakers, you can do it, drink and ask questions. Thank you very much, you both. Thank you very much, Morgan.